take a look at the eye today. And basically, I don't know if in our last presentation we did go through teloceptors, exteroceptors. We did that, right, last week?
Yeah.
Yeah, okay, so we'll start right on the eye. And I love that slide, nice picture. But basically, we're going to look at the eye, but first, there's the functional organ of vision, of course, is the eyeball, but there are also accessory organs, eyelids, lacrimal apparatus, and the extrinsic eye muscles. So let's take a look at those first before we delve into the eyeball itself. So the eyelid is also known as the palpebra, and of course there's an upper and lower eyelid. The palpebra is composed, of course, 4 layers. Outermost is the skin. There is muscle, skeletal muscle actually, and then there is connective tissue, and of course, in contact with the eyeball itself is conjunctiva. I apologize that this slide is a little bit busy, but here we are with the eyelid. Here's this skin part of the eyelid. This is the upper eyelid. You can see the eyelid is obviously closed here. Here's the lower eyelid, and deep to the skin is muscle, as you can see here. This red, let me get my pointer so you can actually see what I'm pointing to. So outermost layer is skin, then a layer of muscle, then connective tissue, and then of course is the conjunctiva, which is seen here. And you can see the conjunctiva covers the eye and is even continuous with the white of the eye, the sclera. Okay, see that, how the conjunctiva comes around, and then here is the conjunctiva inferiorly. Okay, and basically this muscle, that skeletal muscle that elevates the eyeball, is levator palpebrae superioris, and that is under the control of the third cranial nerve, the oculomotor nerve. The conjunctiva, basically what it is, it's a mucous membrane, and it provides protection as well as lubrication for the eyeball. And of course can become inflamed in conjunctivitis, which can be due to viral origin, bacterial origin, or of course, this season, allergic origin, which is what I'm suffering through right now. And conjunctivitis is obviously relatively common. So the lacrimal apparatus, interestingly, it is located, begins with the lacrimal gland, and the lacrimal gland is superolateral to the eyeball. Okay, it's lateral. And what happens is the lacrimal gland secretes tears, which travel across the eyeball itself, and then are picked up at these inferior and superior canaliculi, then taken to the lacrimal sac, which is contiguous with a nasolacrimal duct, which is continuous with the nasal cavity. That is why if you tear a lot, if you're crying, not only do you make a lot of tears, but you have to blow your nose too, because those tears get picked up by the superior and inferior canaliculi, collect in the lacrimal sac, and then travel to the nose. So the nose also gets very watery as a result. And tears themselves, it's mostly fluid, salt fluid, but it also contains an enzyme called lysozyme, which has antibacterial properties. So here's probably why you came, is the external ocular muscles. Okay, so the external ocular muscles move our eyeball. Okay, and how do you feel with these?
This is okay, Professor.
This is good. Okay, yeah. So basically, quick review. The ocular muscles, there's 6 of them. There's a superior rectus, inferior rectus. So you have the 2 rectus, superior and inferior, and then you have medial rectus and lateral rectus, as well as 2 oblique muscles, a superior oblique muscle, as well as an inferior oblique muscle. If you look at the superior oblique muscle, it is actually hooked by a soft tissue ligament called a trochlea, right? And this is looking anteriorly, here's looking laterally. again, superior rectus, inferior rectus, superior oblique. Notice that the superior oblique, as it passes through the trochlea or hook, it kind of passes under the superior rectus into the little bit posterior and back of the eyeball. So when the superior rectus actually contracts, the eyeball, because of the location of the insertion, the eyeball actually looks downward and inward, okay, inferiorly and medially. And that's the opposite of the inferior oblique, which doesn't hook on it by a trochlea, but actually inserts as you can see really well here, posterior and laterally. So when the inferior oblique actually contracts, the eyeball will look up and medial. Okay, so the obliques both turn the eye medial, but they also can elevate or depress the eyeball. Superior oblique, depression, okay, as well as medial rotation, and the inferior oblique elevation as well as medial rotation. And you can basically skip all of that. If you look here, this is a very easy diagram to help you remember where the muscles are, where the movements are, as well as their cranial nerves. So we have left eye, right eye, and we're talking about superior oblique. Superior oblique is obviously located superior to the eyeball as it passes through but because the tendon of superior oblique hooks through the trochlea, it inserts posteriorly and superiorly and a bit laterally. So as a result, when superior oblique functions, the eyeball turns in this direction. Okay, depression means looking down, and medial, towards the nose, if you will. Okay, so if you're looking downwards, if you're looking at something below your left hand as you're standing up, what's going to happen is your right eyeball is going to both eyeballs will depress, obviously, to look down, but your right eyeball will look medially, and your left eyeball goes laterally. So if you're looking down at something over here, okay, what's going to happen is the superior oblique of the right eyeball will fire, and the inferior rectus of the left eyeball will fire like that. Okay, and that will allow you to look downwards. Okay, so that said, the cranial nerves, okay? So basically, to remember the cranial nerves, the cool thing about superior oblique is it's what? Passes through the trochlea, right? And the trochlea is the fourth cranial nerve. If you remember your cranial nerves, trochlear nerve is your fourth. The other outlier is lateral rectus, okay? Lateral rectus, okay, abducts the eyeball away from midline, right? If you're looking laterally, if you're looking out here with your right eyeball, right, you're using lateral rectus, you're abducting your eyeball, correct? And guess what? That's the sixth cranial nerve. The sixth cranial nerve, the name is abducens. Abducens. So cranial nerve 6 is abducens, and that abducts lateral rectus. And that's an easy way to remember that. Okay, so those are the two outliers. Superior oblique is the fourth cranial nerve. That is the trochlear nerve because it passes the trochlear. Lateral rectus abducts the eyeball, so it uses the abducens cranial nerve, which is 6. All of the remaining 4 external eye muscles utilize the third cranial nerve. Okay. You'll probably be asked a question or two on that on the practical as well as the movements. Did your professor go over that, Gayatri?
Yes, Professor.
Excellent, excellent, great. So you feel good with that?
Yes.
Good.
But sometimes it's my problem is find the location, superior and inferior.
Oh, you're okay, right. Superior means you're the high and mighty one, so you're looking up. You're my superior, right? Inferior, you're looking down, right?
Okay.
Lateral, moving, you're looking away from laterally, you're throwing from the side, you're looking at the side. Medial, you're looking toward the midline, medium, okay? Right into the median, okay? So that's how you remember the locations, all right? Just the only thing is the functions, as you can see. Superior rectus does move the eyeball up and laterally, okay? But superior oblique, think of oblique means it's twisted, it's different. Superior oblique, yeah. Superior oblique, instead of, you would think maybe it would make the eyeball look up and medial. No, it makes the eyeball look down. So even though it says superior in the name, superior oblique, because it's oblique means, it goes the opposite way. So it's opposite of superior rectus. Same thing with inferior oblique and inferior rectus. Inferior rectus allows us to look inferiorly or downward and laterally, as you can see here. But inferior oblique is it's the opposite. So inferior oblique actually has us look elevated, looking superiorly, as well as medially. All right. So basically, what I would do is I would take a picture of this slide and then just write it over a few times, and then you will not get anything wrong. And remember, these are the movements. This is not where the muscles are located. That you know already, because obviously superior rectus is here, inferior rectus is here, medial rectus and lateral rectus are in their same positions, but the movements that they do are not exactly where they're located. Okay? So maybe take a picture of that. I'll wait.
No, I took it out.
Oh, you got it. Good. Okay. Excellent. Okay, great. Okay. So here's the same thing. Okay. But let's move on to the structures of the eye. So the eyeball is a is a hollow sphere essentially. And the sphere is made up of 3 layers, okay? And they're called tunics. It's kind of an old-fashioned way of saying layers. So there's an outer layer or outer tunic or outer fibrous tunic. There is a middle vascular tunic, which helps supply sustenance to the inner tunic. And then there is the inner nervous tunic, where actually the magic happens with with actually creating the the impulses necessary based on photoreception. And the structure of the eyeball functions exactly like a 35 millimeter camera. Okay, so light passes through the cornea, then through the pupil opening, okay, which is that black circle that we see in our eyes in the mirror. That's an opening, and then light passes through the lens, and then the lens and cornea help focus an image on the back of the eye here, where the film would be, and the film in our case is the retina. All of this is retina. But in the back area right here, where it says fovea centralis, which is part of a circular area called the macula lutea, the fovea centralis is the area of the retina with the highest concentration of photoreceptors, especially cones. Okay, and if you remember, cones help us, are photoreceptors for light. Rods are photoreceptors for black and white. Okay, this area here in the back of the eye is which cranial nerve? Cranial nerve 2, the optic nerve. So, but as where the optic nerve comes in, we have an area called the blind spot, which is also called the optic disc. So don't confuse optic disc with fovea centralis. Optic disc, there are no photoreceptors, and this is what gives us our characteristic blind spot. And you might have been able to go into Connect and you do the blind spot lab if your instructor assigned it. But you can also look on the internet. It's very cool. It's like it'll be usually like an X and a dot, a certain distance apart, maybe about 3 inches. And if you move the card with one eye closed toward the open eye, the X, if you're looking at the X, the dot will actually disappear at some point. And that is because the dot, the image of the dot, forms over the optic disc. And over the optic disc, we have no photoreceptors. Okay. So let's take a look at these 3 layers more closely. Again, here's the comparison of the eye to a camera. We have eye coming through a lens. Then there's an aperture which controls the amount of light that gets into the camera. The aperture of the eye would be like the iris, okay? And then the pupil is the opening. And of course, the image is formed on film in a 35 millimeter camera, but on our eye, it's actually shown at the back of the retina here. And just like the inside of the camera has to be completely dark, the same thing with the inside of our eye has to be completely dark. Okay, if light is passing through any other area than the what the pupil lets in, our image is going to be distorted. Okay, and if it is even seen at all. Okay, that's one of the functions of the sclera, or the white of the eye, is to actually block out light. Okay, so the side of our eyeball is a dark room. That is why when you look at your eyeball, the pupil pretty much looks black. Okay, because there is no light getting in there. Unless if you're shining a direct light into the pupil, like when you get red eye from a camera, you get red eye because the flash of, if the person is looking directly at the camera and the flash goes, that flash lights up the back of the eyeball here, which is red. It's highly vascular, hence the red eye. So outer tunic is the outer layer, and it's formed from the sclera, which is the white of the eye. Okay, the characteristic white of the eye, and which provides protection for the eye, but also the cornea right here. So the cornea is a transparent part of the eye that is, as you can see here, it's convex. Okay, concave means it would go this way, but it's convex. So it's like a bulge, an anterior bulge in the eye that is transparent, and it helps bend light rays. Believe it or not, Gayatri, most of our focusing is done by the cornea and not the lens, because it's the cornea that represents the where light is bent the most, because light travels through air at a very fast speed, but when it gets to the cornea, it meets a hard, solid surface and then an underlying fluid, and the light rays bend, and that's called refraction. And that helps us actually, when we bend light, like a camera or a microscope or a telescope, it allows us to begin to focus. So the cornea provides most of our focusing ability. Therefore, it's really important. Okay, so this is the cornea out here. And we have the sclera, which is the white of the eye. That's the outer layer. Middle layer. Okay, we have the iris, which is the pigmented portion of our eye. Blue eyes, brown eyes, green eyes, all of that, hazel eyes, all that good stuff is from the iris. And the iris is a circular and longitudinal smooth muscle which actually controls the diameter of the pupil, which is the opening that light passes through to get to the retina. So in high levels of light, the iris constricts the pupil to let in less light. In darker or lower intensity light, the iris will dilate, allowing more light through the pupil, okay? Because light is limited. So iris controls light intensity, and it's right here. So just you have cornea, then iris, and iris. Pupil is the opening. Next, we have the ciliary body. Ciliary body is actually a muscle. And what the ciliary body does is holds the lens in place, and it attaches to the lens by these suspensory ligaments. So we have ciliary body, suspensory ligaments, lens. Okay, ciliary body, suspensory ligaments, lens. And actually lens is kind of the inner tunic, so we're kind of getting ahead of ourselves there. But the ciliary body is what moves the lens back and forth or stretches it up and down for focusing, fine focusing. In the middle, just deep to the sclera, you see this reddish line here? That is called the choroid coat. And what the choroid coat does is it nourishes the eye. It's highly vascular, and it also contains pigments, Gayatri, to help absorb any light that's trying to pass through the sclera. So the sclera plus the choroid coat keeps this area, the posterior cavity of the eye, dark. All right. So once again, cornea, then iris, and pupil, then lens, okay? Here is a good close-up image of that. Again, cornea, which is the anterior bulge that's transparent. Then we have, between the lens and the cornea, we have an anterior chamber, which is filled with a clear fluid called the aqueous humor. Then we have the iris, pupil, lens. Lens is held into place by suspensory ligaments and the ciliary body. Okay, and on the outside of the sclera right here is conjunctiva. Okay, conjunctiva would also continue on the inner surface of the eyelid, the palpebrae. Any questions yet? That's a good slide.
No, no.
Okay. Okay, good. Eye is not too bad, Gayatri. It's not too bad. It's a lot of little structures, but they all kind of make sense, if that makes sense.
Yeah.
They're kind of yeah, they stick with it. They're easy to remember. I don't know why. It's I guess we like eyes as humans.
Because
So the
the life
lens,
is almost, we know some parts, right? That's why easy, I think.
yeah, you're right. We already know a lot about it just by you know, using it and just by, you know, talking and you know, cornea abrasion, we've heard that. We all know about lenses and eyeglasses and of course the whites of the eyes of the sclera. So already we know, and the retina is where the image is formed. So we know that we do know from just regular, you know, outside stuff, many of these structures.
Yeah.
Um, so here's the lens. Let's talk a little bit about the lens. It's, of course, just like the cornea, it's transparent. And whereas the cornea is just convex in one direction, the lens is biconvex, convex anteriorly and convex posteriorly. So we call that biconvex. It lies, of course, behind the iris, behind the pupil and iris. It lies behind the cornea, iris, and pupil, of course. And the lens is essentially composed of many fibers, and it actually is a ball of jelly. Very viscous. In other words, it's very viscous and flexible, especially in newborns. But when you're at age 40, which is my age, the lens becomes inelastic. And that's why older people, you'll see them have to use reading glasses, is because they cannot accommodate. Their lens is not flexible. A lot of that flexibility and hence ability to accommodate, you know, change in looking at accommodation means if you look at something far away and then look something close to you, your lens, you know, will adjust. It will be stretched and moved. In an older person, the lens is not so elastic. So the ability to accommodate from far vision to near vision and vice versa is difficult. So the lens is held in place by suspensory ligaments, which are attached to the ciliary body. Okay, and it is the lens that divides the eye into the anterior and posterior cavity. It's just a little bit an anterior view of the ciliary body. So of course, the opening of the ciliary body is the pupil, and you see a bit of the lens bulging through here in this picture. But the ciliary body is, if you remove the pupil, okay, it is the ciliary body right here. If you remove the iris, it is the ciliary body, which is this red muscle, okay, that actually holds this lens in place, okay? And attaching the lens to the ciliary body are these suspensory ligaments all around the lens. So this shows you that even though the ciliary body we look at in the last slide, Gayatri, here and here, remember this forms a complete circle, okay? And in this slide, we're looking at the ciliary body and lens and suspensory ligaments head on, okay? And they're kind of showing that to us here, okay? So the ciliary body forms a ring around the eye, okay? And they, as you can see, they radiate, almost looks like sun rays, and they're muscles that contract and relax to move the lens. Here's how they move it, and this is called accommodation. So this is weird. When the ciliary, and this might not be asked on lab because it's a little bit more physiological, but when the ciliary muscle is relaxed, the suspensory ligaments become very taut and the eyeball is stretched. When the ciliary muscle becomes contracted, the suspensory ligaments relax and the eyeball becomes rounded. So think when the ciliary muscle is relaxed, the lens becomes stretched and is thin. When the ciliary muscle fibers are contracted, the lens becomes more round, okay? It's almost like when the ciliary muscle is contracted, what happens is it kind of squeezes the lens into a small ball, okay? And this difference between lens shapes, Gayatri, is what is difficult for older people. As you age, you lose that elasticity. This is a very elastic lens that we see here. So if the body needs to thin out the lens, it will relax the ciliary bodies and the lens will thin out, okay? Here, the ciliary bodies, when they contract, will actually squeeze the lens to become more rounded. That's basically accommodation. The iris is, as we said before, is composed of two smooth muscles. There are radial muscles and there are circular muscles inside. The radial muscles, I don't know if you could see it on yours so well, and it's not showing up that great on mine. Radial muscles are on the outside and they're basically radiate toward from the outside of the eye towards the center of the pupil. You can kind of see it right here. If you see these fibers looking in, like this way, this is radial like this. They're always pointing toward the, okay? So that's the outer ring. The inner ring of the iris, the fibers are circular, okay? So they actually basically are like rings around the iris. So basically what happens is dim light stimulates the radial muscles and the pupil will dilate. So in dim light, we have the radial muscles, it opens up the pupil here and more light comes in. Bright light, the circular muscles actually will constrict and we see more of the iris and the pupil diameter is smaller, okay? And then basically, so that's it. So we have radial arranged smooth muscle is on the outside, circular arranged smooth muscle on the inside. So when the circular muscle contracts, we get bright light. When the radial muscle contracts, it opens up the diameter of the pupil and in low levels of light. I don't know if that's going to be on your lab or not, but those are the two smooth muscle layers of the iris, Gayatri. Did you guys go over that in lab?
Yes, that's why I'm looking at now.
Beautiful, beautiful. Okay, any questions on this?
No, Professor.
Excellent, excellent. Okay, good, Gayatri, good. So, aqueous humor. Okay, so now there's two fluid, remember there's two compartments. There's an anterior compartment, which is between the cornea and the lens, and then there's a posterior compartment, which is between the lens and basically the back of the eye, right? So in the anterior compartment here, between the cornea and the lens, is a fluid, a clear fluid called aqueous humor. And the thing with aqueous humor is it basically is secreted in the area behind the ciliary body in here. So the aqueous humor basically flows from between the lens and iris, then flows into most of the anterior chamber of the eye, and then to prevent the intraocular eye pressure from becoming too much, the fluid is absorbed on the side here through what we call the canal of Schlemm or Schlemm, or scleral venous sinus. Okay, if there is a blockage over here of the canal of Schlemm, what can happen is intraocular pressure can become too high, and we can have a situation where the patient goes into glaucoma. Glaucoma becomes dangerous when the intraocular pressure becomes dangerously high for too long, because what that can do is that high eye pressure can actually squeeze off the capillaries that support the structures here, and the patient can actually go lose their vision at the very least. Okay, so the aqueous humor also, this fluid, but it has to be the correct amount of pressure, because that amount of pressure maintains the actual dome-shaped shape of the anterior eye here, with the cornea, which is convex. It prevents the cornea from actually collapsing. Okay, so it has to be just the right amount of pressure. I mean, I don't remember exactly what the level should be, and for some reason, in my
I have
mind's eye,
a question, Professor. If they have
go
any
for it.
the high pressure in eye, do they need any surgery for the eye?
Yeah, well, right away, you probably will put the patient on a medication like a beta blocker. One such would be, it's called it's based on timolol, the beta blocker timolol. It's called Timoptic. It's an eye drop. And what the beta blocker does, Guthrie, when you go into ANP2, when you learn about the vascular system, a beta blocker actually is a medication that allows for blood vessels to close. Okay, so the beta blocker will help lower the pressure in the aqueous humor, okay, by actually, it'll open up the canal of Schlemm. I said it wrong. Beta blocker allows the blood vessel to actually dilate, okay, and when that happens, that will open up the canal of Schlemm a bit and allow for pressure to equilibrate. If as you said, the pressure becomes too much, then yes, surgery is absolutely warranted to drain that fluid and
Yeah, I
prevent.
know, because my
Yeah,
husband had that problem now. That's why I'm asking.
get in his mouth.
No, yeah, but his eyes is too much of tearing and the pain. The doctor said
Oh,
it's something glaucoma in his eye.
glaucoma.
Yeah.
Yeah, yeah. Oh God. Okay. How's he doing now? Everything okay?
No, the eye surgeon told him to do the surgery, I think next month or something, but they gave the eye drop. He taking now.
Okay. Yeah. So your husband may be taking Timolol or some kind of a beta blocker to help control this pressure here, or maybe an anti-inflammatory, or both. But yeah, that's basically what happens with glaucoma over here.
Mhm.
So any questions on the structures here?
Yeah.
Great, excellent. Okay, so let's move along. Okay, so now we're gonna look at the inner tunic. A lot of these structures we did talk about. We have the retina, okay, in the back of the eye. And the retina, as you know, contains visual receptors. It's continuous with the optic nerve, and it ends just behind the margin of the ciliary body. So it basically, the remainder of the back of the eyeball is all retina. And then there's the macula lutea, which is a yellowish spot in the retina. And in the center of the macula lutea means yellow, macula means spot. In the center of the macula lutea is the fovea centralis, where we have the highest degree of cones, of the highest concentration of photoreceptors, especially cones. The optic disc is the blind spot that we talked about. And then, of course, what helps maintain the round shape of the eyeball is in vitreous humor, which is, whereas the aqueous humor is a fluid, okay, a clear fluid, the vitreous humor is a clear gel. And this gel keeps this perfect round shape, or nearly perfect round shape of the eye. If the eye is allowed to change its shape, we can get something called astigmatism, and that is where the image no longer focuses correctly on the retina, and that patient will need glasses. So the vitreous humor is a clear gel that helps, that basically is within the posterior cavity, helps keep the shape of the eye. So the retina basically is all of this yellow area. And remember, yellow in anatomy models means nerve. Okay, so this is retina, all here, retina. And notice that the retina begins where the ciliary body leaves off. Same thing here. Ciliary body leaves off here. Retina begins right there. And the retina is all this back surface. And then this area of the retina right here, a yellowish disc, would be the macula lutea, and the center of the macula lutea is the fovea centralis. It's too bad they don't draw in the macula lutea for us in this slide, but this is where it is. It's just around the fovea centralis. So if you see that on a practical, just make sure fovea centralis is the tiny spot, but the yellow ring or the yellow spot that the fovea is in is the macula lutea. Okay, and also what the choroid coat, I'm sorry, what the vitreous humor does is by maintaining, it presses the choroid coat, or the retina rather, against the middle layer, which is the choroid coat. Okay, remember the choroid coat has vascular structures as well as light blocking pigments. Okay, so basically the last little area that you might be tested on is right here. Okay, so this is basically fibers, and then we have the area of the choroid coat, and here itself, this whole spot is the retina. So these are the layers of the retina. So we have sclera, choroid coat, which is highly vascular, and then retina. So light, Gayatri, as you see in this diagram, passes this direction, obviously through the cornea, through the pupil, then via the lens, and then the light is focused onto the retina, which is this, and here are the layers of the retina. The first layer of the retina is our nerve fibers. Then you can see layers of ganglion cells, amacrine cells, horizontal cells, and eventually light gets to these photoreceptors, which are rods and cones. Cones are these pinkish cone-shaped. They are sensitive to light. Rods are these longer purple, skinnier photoreceptors. So basically what happens is light passes through this nerve fibers and ganglion cells, horizontal cells, and then gets to these photoreceptors. The photoreceptors, upon seeing light or being exposed to light rays, Gayatri, actually generate impulses, depolarizations, which actually send impulses to these connecting neurons, horizontal cells, amacrine cells, ganglion cells. And what these cells do, Gayatri, is they kind of fine tune, if you will, the impulses to make a nice sharp image of light, which is then, that impulse is then taken by these nerve fibers towards the optic nerve, which is cranial nerve number 2. So it's kind of interesting, right? That the light has to pass through all of this nerve and cellular material to the photoreceptors. Then the photoreceptors send impulses which are picked up by these modifying neurons, and these neurons then will kind of fine tune or modify the image and then send the impulse to the optic nerve, to the optic tract. Okay, and then obviously to the occipital lobe in the brain. So basically, again, what these horizontal and amacrine cells do here, Gayatri, is they modify the impulses that are sent from rods and cones. Because rods and cones, their job is basically to just turn light energy into electrical energy. That's it. It is the ability of these horizontal and amacrine cells to actually kind of fine-tune those impulses before they're sent to the optic nerve. Then they're sent via the optic nerve, nerve fibers to the optic nerve, and then eventually to the occipital lobe. So then we see, quote unquote, the images in our brain. Okay. And it is these ganglion cells here which actually provide pathway for the impulses. So the impulse is picked up by a photoreceptor, then it is modified by a horizontal and amacrine cell, and then the impulse is then triggered by these ganglion cells to reach the nerve fibers along the way to the optic nerve. So that's basically what happens here. So those are the areas that you should look at: sclera, choroid coat, pigmented epithelium, cones, rods, horizontal cells, amacrine cells, ganglion cells, and then nerve fibers. Okay, that's basically the retina right there. Any questions?
Not Professor.
Good. Okay, great. So these are the 3 layers of the eye. Nothing much really that we haven't already said. That's just in a table form. Okay, last thing would be rods and cones. What's the difference? Rods are those long, thin projections that contain light-sensitive pigment. It's called rhodopsin. That's the name, hence the name rod. They are 100 times more sensitive to light than cones are. And rods therefore produce vision in dim light, colorless vision, and produce outlines of objects. So it's when you wake up in the middle of the night, Gayatri, and there's no light on in the room, but there's just a little bit of light coming through the window. You ever look around your room and you're like, why is everything in black and white, right? Everything is kind of like hazy and in black and white, and you're able to, to get to the bathroom or whatever you want to do. But then you turn the light on, and now suddenly you can see sharp images, colors, okay? So in low light, it's only your rods that are working. And rods will produce vision in dim light, but that vision will be colorless and will just be like general hazy outlines of objects. Whereas when you turn the light on, now you can use your cones. So cones are short, blunt photoreceptors that contain any of the three color-sensitive light pigments called erythrolob, chlorolob, or cyanolob. And cones produce vision in bright light. You've turned your light on. Now you can use your cones, and now you can see sharp images, and you can see color. Okay, and as we said a couple of times, the highest concentration of cones are in your fovea centralis. Here are rods. Here are cones. Okay, light-sensitive photoreceptors. These are your pigmented epithelium. Here are the ganglion cells, and maybe your amacrine cells could be found in here. But ganglion cells then focus the image onto nerve fibers. Notice though, the artist drew about 5 rods here, and they all combine to form one nerve fiber. Whereas the cones, there's 3 cones, and each of them have their own nerve fibers. Okay, so that means that cones give you much more sensitive detail, or much more detail, because each cone has its own nerve fiber, whereas here it's one nerve fiber for 5 rods. So the cones are going to give you much more detail in the vision. And then here we are again. These are cones, Gayatri. They're somewhat cone-shaped, like long, elongated cones, and these are rods next to them. Okay. So cones tend to, if you see a picture like this and you're not sure, the cones are wider and they're more rod-shaped. The rods are just more thinner, just as you see here compared to here. Okay. So the visual pigments, rods use rhodopsin, and rhodopsin basically decomposes in the presence of light and triggers a complex series of reactions that initiate nerve impulses which travel along the optic nerve. The pigments on cones are erythrolob, chlorolob, cyanolob, and each of these photoreceptor pigments are tuned to a certain wavelength of light which corresponds to color. Erythrolob, like erythrocyte, erythro means red. So erythrolob, cones with erythrolob pigment respond to red. Chlorolob, like chlorophyll, green, responds to green. Cyanolob, like cyan, responds to blue. Easy to remember. Okay, so the color perceived depends on the mixtures of which cones are stimulated. Okay, so if you're looking at something purple, your erythrolob and your cyanolob cones will be stimulated because red and blue make purple. You will not use your chlorolob. Your cones that contain chlorolob will not fire if you're looking at a purple, very purple image, or violaceous, if you will. Okay, the nervous system pathway for light is, here's an image. Light rays from the image travel to the left and right eye, respectively. That image then is formed in the retina, which is in the back of the eyeball. The impulses then travel along the optic nerve to the optic chiasm. Chiasm is where the optic nerves cross over. So some images from the left eye, as you see here, some will be formed on the left occipital lobe, as you can see here, but also some fibers will travel to the right occipital lobe here. Notice that along the way to the occipital lobe, the images first pass through the superior colliculus. And if you remember your superior colliculus, did they draw that over here or no? This colliculi are right here. Superior colliculus, actually, if you remember from your nervous system anatomy, your brain anatomy, your superior colliculus helps basically turn your head toward a very sudden bright light. It's a reflex, okay? And it is basically, if there's a bright light that basically like lightning, we will, as basic humans, we will turn our heads. Whoa, what was that? Okay, it's a self-preservation reflex. Okay, and you remember the superior colliculus, inferior colliculus, forming the corpora quadrigemina. Okay, so here is the summary of the visual pathway. Rods and cones, synapse with a bipolar neuron, which converges on a ganglion cell. Then this image, the impulse continues, the ganglion cells continue to form the optic disc, and then the image travels along the optic nerve towards the brain. At the diencephalon, there is the optic chiasm where fibers cross to the other side, as you saw in the last picture. The thalamus is the relay area of the diencephalon, and will decide where do they go. They're going to go to the occipital lobe, but along the way, they will pass through the superior colliculi and, of course, then the visual cortex of the occipital lobe. Amacrine cells and horizontal cells, as you saw, they aid and inhibit the communication between ganglion cells, and that helps, as we said, fine-tune the image. Some disorders of vision. We have presbyopia, where the lens loses elasticity. That's, especially by age 40, the lens has essentially lost almost all of its elasticity. Glaucoma is where there's a blocked circulation of aqueous humor, and then what happens is the intraocular pressure inside the anterior chamber is dangerously high, and that starts to block blood vessels as well as cause pain. Cataracts is when the lens loses its transparency. Okay, and if you look at the eyes of someone or an animal with cataract, you can actually see a cloudiness in their lens. You can actually see their eye looking cloudy, and that's called arcus senilis, which is pathognomonic for cataracts. Astigmatism is an irregular curvature of the lens or cornea, and then a color blindness is when one or more cone type can be missing or malfunctioning, and night blindness is actually, it can be due to a lack of vitamin A or where rods are not activated in dim light. This would be a convex versus concave lens. You can see the convex, which is used by our eyes, helps converge light rays. Concave lens would be used by a telescope, and that will help diverge light rays to magnify an image. So these are refraction disorders, myopia versus hyperopia. So nearsightedness is myopia, farsightedness is hyperopia, and look at the shapes of the eyeball here. In nearsightedness, in a perfect eye, which is the center, right? I don't know why they drew it in the center. Perfect circular eye, okay? Someone that doesn't need glasses, notice here's the light rays coming in. They are converged because it's a convex lens into an image that is sharpest focused right at the retina, right at the fovea centralis. Someone who is nearsighted or myopia, the light rays still focus at the same spot, see that? But because the eye is too oblong, it's too long, the rays then cross and start to diverge again, and we get a blurry image at the back of the retina because the retina is too far away. The retina should be over here, not back here, okay? So what we do as a result is that person will wear eyeglasses, and that will help focus the light at the right portion of the eye, back here, okay? In farsightedness or hyperopia, the eye is actually too short, if you will, okay? So the retina actually occurs before the point of focus. And what happens is the image is blurry or distorted. So that patient, you will give a convex lens to, which will help focus the image at the right portion, the portion of the eye, as you can see here, via the red line, the orange line right there. Okay, so that's how we use corrective lenses for nearsightedness and farsightedness. I don't know if that'll be on your practical or not, but it's just kind of interesting. It's kind of cool anyway. There are here, but Gayatri, from the Khan Academy, which is really good, a YouTube video for the eye that you can review if you want to look at the function, as well as some of the anatomy. But I think you sound like you have a really good, a good grasp of it. And I hope that this review helped out a bit. Okay.
It's very helpful.
Okay, Gayatri, thank you so much. Good luck.
Where I can
Yes.
find this recording video?
This video, you should be able to use your guest link, and you can just go into my classroom and you can see this video as well as actually all of our lab videos that are still up. I think Blackboard keeps like the last month of videos up, so our video will be there. Okay.
The same
If you have trouble,
when I
same room, same link, same room. Yeah, just go to the part on the top left where you can click on. I'll tell you exactly what it is. You can click on where it says course room. Just go above that. You'll see 3 lines. Where it says course room, go above that. You'll see like those 3 lines. Click on that, and you can see the videos. You'll see them listed, or sessions, and just find our session, which is obviously on the 12th of May.
Thank you so much, Professor, give me this time.
Oh, you're welcome, Gayatri. Again, thanks for, I'm glad we were able to hook up, and good luck on the practical today. Good luck in your semester, and I hope to see you around campus soon, okay?
Thank you so much, Professor.
Anytime, Gayatri. It was nice to spend the semester with you.
Okay, thank you so much.
Okay, bye-bye.